Welcome. What is abortion? Ending of a pregnancy. Why is it controversial? Abortion is the ending of a pregnancy by removal or expulsion of an embryo or fetus before it can survive outside the uterus. An abortion that occurs without intervention is known as a miscarriage or spontaneous abortion. When deliberate steps are taken to end a pregnancy, it is called an induced abortion, or less frequently induced miscarriage. The unmodified word abortion generally refers to an induced abortion. A similar procedure after the fetus has potential to survive outside the womb is known as a late termination of pregnancy, or less accurately is a late-term abortion. When properly done, abortion is one of the safest procedures in medicine, but unsafe abortion is a major cause of maternal death, especially in the developing world. Making safe abortion legal and accessible reduces maternal deaths. It is safer than childbirth, which has a 14 times higher risk of death in the United States. Modern methods use medication or surgery for abortions. The drug mifepristone in combination with prostaglandin appears to be as safe and effective as surgery during the first and second trimester of pregnancy. The most common surgical technique involves dilating the cervix and using a suction device. Birth control, such as the pill or intrauterine devices, can be used immediately following abortion. When performed legally and safely on a woman who desires it, induced abortions do not increase the risk of long-term mental or physical problems. In contrast, unsafe abortions cause 47,000 deaths and 5 million hospital admissions each year. The World Health Organization recommends safe and legal abortions be available to all women. Around 56 million abortions are performed each year in the world, with about 45% done unsafely. Abortion rates changed little between 2003 and 2008, before which they decreased for at least 2 decades as access to family planning and birth control increased. As of 2018, 37% of the world's women had access to legal abortions without limits as to reason. Countries that permit abortions have different limits on how late in pregnancy abortion is allowed. Historically, abortions have been attempted using herbal medicines, sharp tools, forceful massage, or through other traditional methods. Abortion laws and cultural or religious views of abortions are different around the world. In some areas, abortion is legal only in specific cases such as rape, problems with the fetus, poverty, risk to a woman's health, or incest. There is debate over the moral, ethical, and legal issues of abortion. Those who oppose abortion often argue that an embryo or fetus is a human with a right to life, and they may compare abortion to murder. Those who support the legality of abortion often hold that it is part of a woman's right to make decisions about her own body. Others favor legal and accessible abortion as a public health measure. Types. Induced. An induced abortion may be classified as therapeutic or elective. Approximately 205 million pregnancies occur each year worldwide. Over a third are unintended and about a fifth end in induced abortion. Most abortions result from unintended pregnancies. In the United Kingdom, 1 to 2% of abortions are done due to genetic problems in the fetus. A pregnancy can be intentionally aborted in several ways. The manner selected often depends upon the gestational age of the embryo or fetus, which increases in size as the pregnancy progresses. Specific procedures may also be selected due to legality, regional availability, and doctor or a woman's personal preference. Reasons for procuring induced abortions are typically characterized as either therapeutic or elective. An abortion is medically referred to as a therapeutic abortion when it is performed to save the life of the pregnant woman, to prevent harm to the woman's physical or mental health, to terminate a pregnancy where indications are that the child will have a significantly increased chance of mortality or morbidity, or to selectively reduce the number of fetuses to lessen health risks associated with multiple pregnancy. An abortion is referred to as an elective or voluntary abortion when it is performed at the request of the woman for non-medical reasons. Confusion sometimes arises over the term elective because elective surgery generally refers to all scheduled surgery, whether medically necessary or not. Spontaneous miscarriage, also known as spontaneous abortion, is the unintentional expulsion of an embryo or fetus before the 24th week of gestation. A pregnancy that ends before 37 weeks of gestation, resulting in a live-born infant, is a premature birth or a preterm birth. When a fetus dies in utero, after viability, or during delivery, it is usually termed stillborn. Premature births and stillbirths are generally not considered to be miscarriages, although usage of these terms can sometimes overlap. Only 30% to 50% of conceptions progress past the first trimester. The vast majority of those that do not progress are lost before the woman is aware of the conception, and many pregnancies are lost before medical practitioners can detect an embryo. Between 15% and 30% of known pregnancies end in clinically apparent miscarriage, depending upon the age and health of the pregnant woman. 80% of these spontaneous abortions happen in the first trimester. The most common cause of spontaneous abortion during the first trimester is chromosomal abnormalities of the embryo or fetus, accounting for at least 50% of sampled early pregnancy losses. Other causes include vascular disease, diabetes, other hormonal problems, infection, and abnormalities of the uterus. Advancing maternal age and a woman's history of previous spontaneous abortions are the two leading factors associated with a greater risk of spontaneous abortion. A spontaneous abortion can also be caused by accidental trauma. Intentional trauma or stress to cause miscarriage is considered induced abortion or feticide. Methods. Gestational age may determine which abortion methods are practiced. Medical abortions are those induced by abortifacient pharmaceuticals. Medical abortion became an alternative method of abortion with the availability of prostaglandin analogs in the 1970s and the antiprogestogen mifepristone in the 1980s. The most common early first trimester medical abortion regimens use mifepristone in combination with misoprostol up to 10 weeks gestational age. Methotrexate in combination with a prostaglandin analog up to 7 weeks gestation, or a prostaglandin analog alone. Mifepristone misoprostol combination regimens work faster and are more effective at later gestational ages than methotrexate misoprostol combination regimens. And combination regimens are more effective than misoprostol alone. This regimen is effective in the second trimester. Medical abortion regimens involving mifepristone followed by misoprostol in the cheek between 24 and 48 hours later are effective when performed before 70 days gestation. In very early abortions, up to 7 weeks gestation, medical abortion using a mifepristone misoprostol combination regimen is considered to be more effective than surgical abortion, especially when clinical practice does not include detailed inspection of aspirated tissue. Early medical abortion regimens using mifepristone, followed 24-48 hours later by buccal or vaginal misoprostol, are 98% effective up to 9 weeks gestational age. From 9 to 10 weeks, efficacy decreases modestly to 94%. If medical abortion fails, surgical abortion must be used to complete the procedure. Early medical abortions account for the majority of abortions before 9 weeks gestation in Britain, France, Switzerland, and the Nordic countries. In the United States, the percentage of early medical abortions performed in non-hospital facilities is 31% as of 2014. Medical abortion regimens using mifepristone in combination with a prostaglandin analog are the most common methods used for second trimester abortions in Canada. Most of Europe, China, and India, in contrast to the United States where 96% of second trimester abortions are performed surgically by dilation and evacuation. Surgical. Up to 15 weeks gestation, suction aspiration, or vacuum aspiration are the most common surgical methods of induced abortion. Manual vacuum aspiration consists of removing the fetus or embryo, placenta, and membranes by suction using a manual syringe, while electric vacuum aspiration uses an electric pump. These techniques can both be used very early in pregnancy. MVA can be used up to 14 weeks, but is more often used earlier. In the US, EVA can be used later. MVA, also known as mini-suction and menstrual extraction or EVA, can be used in very early pregnancy when cervical dilation may not be required. Dilation and curettage refers to opening the cervix and removing tissue via suction or sharp instruments. D&C is a standard gynecological procedure performed for a variety of reasons, including examination of the uterine lining for possible malignancy, investigation of abnormal bleeding, and abortion. The World Health Organization recommends sharp curettage only when suction aspiration is unavailable. Dilation and evacuation, used after 12 to 16 weeks, consists of opening the cervix and emptying the uterus using surgical instruments and suction. D&E is performed vaginally and does not require an incision. Intact dilation and extraction refers to a variant of D&E sometimes used after 18 to 20 weeks when removal of an intact fetus improves surgical safety or for other reasons. Abortion may also be performed surgically by hysterotomy or gravid hysterectomy. Hysterotomy abortion is a procedure similar to a cesarean section and is performed under general anesthesia. It requires a smaller incision than a cesarean section and can be used during later stages of pregnancy. Gravid hysterectomy refers to removal of the whole uterus while still containing the pregnancy. Hysterotomy and hysterectomy are associated with much higher rates of maternal morbidity and mortality than D&E or induction abortion. First trimester procedures can generally be performed using local anesthesia, while second trimester methods may require deep sedation or general anesthesia. Labor induction abortion. In places lacking the necessary medical skill for dilation and extraction, or where preferred by practitioners, an abortion can be induced by first inducing labor and then inducing fetal demise if necessary. This is sometimes called induced miscarriage. This procedure may be performed from 13 weeks gestation to the third trimester. Although it is very uncommon in the United States, more than 80% of induced abortions throughout the second trimester are labor-induced abortions in Sweden and other nearby countries. Only limited data are available comparing this method with dilation and extraction. Unlike D&E, labor-induced abortions after 18 weeks may be complicated by the occurrence of brief fetal survival, which may be legally characterized as live birth. For this reason, labor-induced abortion is legally risky in the United States. Safety. The health risks of abortion depend principally upon whether the procedure is performed safely or unsafely. The World Health Organization defines unsafe abortions as those performed by unskilled individuals, with hazardous equipment, or in unsanitary facilities. Legal abortions performed in the developed world are among the safest procedures in medicine. In the United States, as of 2012, abortion was estimated to be about 14 times safer for women than childbirth. CDC estimated in 2019 that U.S. pregnancy-related mortality was 17.2 maternal deaths per 100,000 live births, while the U.S. abortion mortality rate is 0.7 maternal deaths per 100,000 procedures. In the UK, guidelines of the Royal College of Obstetricians and Gynecologists state that women should be advised that abortion is generally safer than continuing a pregnancy to term. Worldwide, on average, abortion is safer than carrying a pregnancy to term. A 2007 study reported that 26% of all pregnancies worldwide are terminated by induced abortion, whereas deaths from improperly performed procedures constitute 13% of maternal mortality globally. In Indonesia in 2000 it was estimated that 2 million pregnancies ended in abortion, 4.5 million pregnancies were carried to term, and 14 to 16% of maternal deaths resulted from abortion. In the US from 2000 to 2009, abortion had a lower mortality rate than plastic surgery, and a similar or lower mortality rate than running a marathon. 5 years after seeking abortion services, women who gave birth after being denied an abortion reported worse health than women who had either first or second trimester abortions. The risk of abortion-related mortality increases with gestational age, but remains lower than that of childbirth. Outpatient abortion is as safe from 64 to 70 days gestation as it before 63 days. The reasons why women have abortions are diverse and vary across the world. Some of the reasons may include an inability to afford a child, domestic violence, lack of support, feeling they are too young, and the wish to complete education or advance a career. Additional reasons include not being willing to raise a child conceived as a result of rape or incest. Induced abortion has long been the source of considerable debate. Ethical, moral, philosophical, biological, religious, and legal issues surrounding abortion are related to value systems. Opinions of abortion may be about fetal rights, governmental authority, and women's rights. In both public and private debate, arguments presented in favor of or against abortion access focus on either the moral permissibility of an induced abortion or justification of laws permitting or restricting abortion. The World Medical Association Declaration on Therapeutic Abortion notes, circumstances bringing the interests of a mother into conflict with the interests of her unborn child create a dilemma and raise the question as to whether or not the pregnancy should be deliberately terminated. Abortion debates, especially pertaining to abortion laws, are often spearheaded by groups advocating one of these two positions. Anti-abortion groups who favor greater legal restrictions on abortion, including complete prohibition, most often describe themselves as pro-life, while abortion rights groups who are against such legal restrictions describe themselves as pro-choice. Generally, the former position argues that a human fetus is a human person with a right to live, making abortion morally the same as murder. The latter position argues that a woman has certain reproductive rights, especially the right to decide whether or not to carry a pregnancy to term. What is abortion? Ending of a pregnancy. Why is it controversial? Thank you for watching this video. Goodbye.